Good morning everyone. Today I am presenting JC on the distribution of novel biomarkers in carcinoma in situ, microinvasive and squamous cell carcinoma of the uterine cervix. This article was done by Alcina F. Nicole et al. In the Institute of Infectious Diseases, Evandro Chagas and Rio de Janeiro, Brazil. And this article was selected from Annals of Diagnostic Pathology. Introduction. Uterine cervical cancer is the fourth most frequent cancer in women worldwide, representing 7.9% of all female cancers, and it accounts for 7.5% of all female cancer deaths. The incidence of cervical cancer can be reduced through screening programs followed by early diagnosis and treatment, and through the HPV vaccine that is highly effective if administered prior to the infection. The use of targeted approaches has recently improved clinical outcomes in a variety of cancers. The discovery of novel targeted therapeutics requires a comprehensive understanding of pathogenesis of the disease, which in turn is facilitated by in situ analysis, as this allows the precise localization of given target to dysplastic cells as they progress to cancer and concomitant host response. Using this approach, PDL1 expression was shown to be significantly greater in cervical squamous cell carcinoma compared to other gynecologic malignancies. HPV infection in particular induces a broad spectrum host response that involves major pathways such as toll-like receptors and NFK beta. In this regard, they recently described several downstream proteins of these two pathways that include importin beta, exportin 5, CCLIP, MCL1 and PDL1, as well as the standard biomarkers like Ki67 and P16 that are markedly increase in cervical intraepithelial neoplasm 1. The importin beta and exportin 5 are key proteins in the transport of RNAs and proteins into and out of the nucleus. The cells often use such nuclear trafficking to repress or activate constituently expressed proteins such as P53 and NFK beta. The HPV E6 protein can't degrade P53 if exportin 5 mediated nuclear export of P53 is blocked. Further, the apoptosis inhibitory protein, that is CCLIP, is upregulated by viruses and malignant cells to upgrade cell death, as does MCL1 that suppresses the back-and-backs induced apoptosis. Materials methods. A cross-sectional study that includes tissue microarray slides of formalin fixed and paraffin embedded squamous cell carcinoma were obtained. Additionally, 10 cases included LEAP cervical excision diagnosed as microinvasive squamous cell carcinoma, and 2 gynecologic pathologists evaluated the course and LEAP and arrived at a consensus diagnosis for CIN3 and microinvasive or deeply invasive squamous cell carcinoma. Negative control and positive control were considered. IHCSA, the immunohistochemistry protocol was carried out. Cervical specimens were tested for following antigens like CFLIP, importin beta, exportin 5, P16, PDL1, Ki67, MLC1, HPV consensus L1 capsid protein. Testing was performed on automated ELISA bond platform. Statistical analysis were carried out and p-value less than 0.05 were considered positive. Marked overexpression of selected biomarkers in squamous cell carcinoma. In cervical cancer, tissue microarray was analyzed that included 60 SEC and normal adjacent cervical tissues. The woman's age distribution was between 30 to 39 in 10%, 40 to 49 in 43%, and above 50 and above is in 46.7%. Most of the tumors were grade 2, accounting 60%. Each of the 4 putative biomarkers such as importin beta, exportin 5, MCL1 and CFLIP, and also P16 and Ki67 was scored in a blinded fashion. 51% of the cervical ACC tissue showed a strong signal in invasive cancer cells for the PDL1. The proliferation marker Ki67 was used to compare the 2 different methods of quantification, and excellent agreement was found. The combination of the samples with intermediate, that is 2 plus, and strong expression was defined as marked overexpression of the given marker. Benign cervical squamous epithelia did show a signal for Ki67 and exportin 5, but this was restricted to the scattered cells in the basal zone. Here, this is a table depicting expression of importin beta, exportin 5, P67 and other biomarkers in the cervical SCC. Here, this is the photomicrograph of SCC and other biomarkers. In the first photograph, we can see H&D section of the cervical intraepithelial neoplasm type 1. In the photograph P, this is, we can see exportin 5 expression, which was limited to the lower two-third of the CIN1 lesion. And in third photograph, we can notice HPV 16 DNA, which is expressed in the upper one-third of the CIN1. And fourth photograph, we can see HPV 16 that is showing typical punctant pattern in the squamous cell carcinoma cases. PDL1 is a highly selective marker of microinvasive squamous cell carcinoma versus carcinoma in situ. 10 lip cervical biopsies that contained microinvasive squamous cell carcinoma were available for the study. The microinvasive component in each case was less than 3 mm in depth and less than 5 mm in lateral extension, with no definitive area of lymphovascular invasion and margins were clear. In each case, there was extensive CIN3, that is referred to as carcinoma in situ, where it was located within 5 mm of the microinvasive disease. Quantification of each biomarker was done with the Inform computer-based system. The most striking difference was highly significant increase in the PDL1 expression in microinvasive carcinoma versus carcinoma in situ. The near loss of PDL1 in CIN3 or CIS, which means that this protein is downregulated as the lesion progress from CIA1, since PDL1 is strongly expressed in the paravasal cells in the latter. HPV16, 18, E6 or 7 RNA were highly expressed in CIS and CIN3, whereas the oncogenic viral RNAs are rarely detected in the CIN1. This is the microphotograph of the SCC of cervix. In the first, there is an expression of Ki67, which shows strong, that is more than 90% of the signal positivity in the CIS, and we can also notice a smaller percentage of cells in the formation of nest in the microinvasive SCC, which is marked by the circle. Photograph 2 and C, for B and C are of CI with several foci of microinvasive squamous cell carcinoma of PDL1, which is not expressed in the CIS but strongly expressed in the microinvasive cancer. Using the stringent criterion of p-value less than 0.01, we are comparing CIS to microinvasive squamous cell carcinoma. Then beyond PDL1 overexpression, only the Ki67 index was significantly different in microinvasive squamous cell carcinoma versus CIS, although it was much decreased in the microinvasive component. Coming to Kasky cells versus C33A cells. Kasky cells are nothing but HPV16 positive cells, whereas C33A cells are nothing but HPV negative cells. They studied the effect of HPV infection on expression of the different biomarkers. There was a more than 4-fold increase in the expression of P67, importin beta and exportin 5 and PDL1 in the Kasky cells when compared to the C33A cells. Discussion. The precursors lesions that are prerequisite for the development of cervical cancer may be the best characterized among human carcinomas. CIN1 or low-grade SIL, which represent acute HPV infection, evolves in about 30% of cases to high-grade CIN, that is 2 and 3, that is obligatory precursor to the invasive lesion. CIN3 is now rarely referred to as carcinoma in situ, although in this study the term CIS was restricted to CIN3 in the immediate vicinity of microinvasive carcinoma strictly for the statistical analysis. In this paper, they present molecular data that assist in clarifying these questions by underscoring the following. CIN1 is marked by the expression of multiple proteins that are present in the parabasal zone of the lesion that co-express with the low copy relatively quiescent viral DNA. The progression to the CIN3 leads to the loss of some of these biomarkers and the continued expression of P16 and Ki67 with marked upregulation of the viral oncoproteins like E6 and E7. CIS and CIN3 are molecularly indistinguishable relative to these biomarkers. Microinvasive squamous cell carcinoma can be differentiated on the molecular basis from CIS by marked increased PDL1 and decreased Ki67. As the lesion progresses to deeply invasive squamous cell carcinoma, Ki67 and importin are upregulated and PDL1 increases. It was evident that PDL1 expression in microinvasive SCC of cervix was predominantly from the invasive squamous cell carcinoma as compared to deeply invasive squamous cell carcinoma of the cervix, whereas mononuclear inflammatory infiltrates including CD8 cells and macrophages were primary source of PDL1. This data suggests that an important molecular switch during evolution of CIS to microinvasion is the acquisition of PDL1 expression, and that in time, as the tumor becomes deeply invasive, an immune response may be mounted against the tumor where PDL1 expression shifts to the immune cells. Coming to abstract, importin beta, exportin 5, P67 and other biomarkers overexpressed in the majority of CIN1 lesion. These biomarkers plus HPV6/7 RNA were analyzed in CIS, microinvasive and squamous cell carcinoma of the uterine cervix and cervical carcinoma cell lines. Only P16 and Ki67 continued to be overexpressed in CIS with concomitant marked increase in E6 and E7 RNA. There was a highly significant increase in PDL1 expression and decrease in Ki67 in microinvasive cancer. As the lesion progresses to SCC, P16, E6, 7 RNA remains strongly overexpressed with concomitant overexpression of importin beta and Ki67. HPV positive Kasky cells showed significant elevation in P16, importin beta, exportin 5, PDL1. The data suggests that PDL1 may be useful biomarker to differentiate CIS from the microinvasive cancer, and thus anti-PDL1 therapy may inhibit progression of CIS to the invasive stage. Thank you.